So
everybody.
I'm thinking we can start the recording now. Thank you. Dr. Okore, you can go on. The recording has started.
Okay, it has started. Okay. Oh, good evening. Thank you, everyone. Today we're looking at pulmonary hypertension. This is the outline we'll be using. So, like we all know, pulmonary hypertension is defined by a mean pulmonary arterial pressure of more than 20 millimeters of mercury at rest by measured by right heart catheterization. Of course, previously the cutoff used to be 25. The former definition, because this definition is according to the 2022 guidelines, the 2022 ESC guideline. The former definition used to have a mean pulmonary arterial pressure at rest more than or equal to 25 millimeter of mercury and exercise more than 30 millimeter of mercury. Okay, but they brought down the cutoff to 20 in order to get early detection, and of course, early detection will lead to early treatment, and early treatment has shown improved mortality. Okay, improved mortality, even improved outcomes. Okay, so that's why the definition was brought down. Okay, this also was brought down as a result of in 2009 there was a study done by COVAX, where they got so many, I can't remember how many patients now, but they got a lot of normal patients and did right heart caths on them. Okay, and they found out that the average mean pulmonary artery pressure was 14 plus or minus 3 millimeter of mercury. Okay, so by the time they did, that's how they arrived at 20 after doing 2 standard deviations of normal. Okay, so and they also removed the exercise criteria because it was found out that a lot of those normal patients had high pulmonary pressures on exercise. In fact, up to 50% of them had high pulmonary pressures on exercise. So would all of them be abnormal? So they felt that that exercise criteria was not actually correct, so it was removed. Okay. Now, pulmonary hypertension is according to different combination of hemodynamics and values, and a hemodynamic classification of pulmonary hypertension has been proposed. So this it was now divided into two, pre and post capillary. Post capillary is due to increase in pulmonary venous pressure seen in left-sided heart diseases. So post capillary is actually exclusively is basically group 2 pulmonary hypertension that gives you the post capillary. Okay, while pre-capillary is due to pulmonary vascular remodeling. Okay, this remodeling of the pulmonary vasculature leads to increased pulmonary vascular resistance. Okay, over time, it will now give you pulmonary hypertension. So group 1, 3, 4, okay, will be pre-capillary. Okay, now to differentiate these two, what is used is the pulmonary artery wedge pressure. Of course, we know and pulmonary artery wedge pressure is a surrogate for the LV end diastolic pressure. So to differentiate these two, the pulmonary artery wedge pressure is elevated. That's more than 15 millimeters of mercury. So it's elevated in post-capillary, while it is normal in pre-capillary. Okay, so I've said this, normal mean pulmonary artery pressure at rest is 14 plus or minus 3, an upper limit of normal of 20. Okay, mean capillary wedge pressure, the normal is 6 plus or minus 2. And of course, we know normal cardiac output is approximately 5 liters per minute. Now, there is a fall in the pressure gradient across the lung circulation. This fall is known as the transpulmonary gradient. And this gradient reflects difference between the mean pulmonary artery pressure and the mean pulmonary capillary wedge pressure. This normal difference is 6 plus or minus 2. Okay. So to get the pulmonary vascular resistance, this is the formula used. The mean pulmonary artery pressure is reasonable minus the mean pulmonary capillary wedge pressure all over the cardiac output. Okay. If you use the values, if you put in the values, that if you use 14 minus 6 over cardiac output of 5 or 5.5, you get approximately 1.5 millimeter mercury per liter per minute, which is now the unit for this is now Woods unit, which is given as 1.5 Woods units. Okay, so the current definition for exercise pulmonary hypertension is you now have to they now imputed cardiac output. Okay, so it's defined as when the mean pulmonary artery pressure over the cardiac output slope is more than 3 millimeter mercury per liter per minute. Okay, between rest and exercise. Okay, and it said that a pathological increase in pulmonary pressure during exercise is associated with impaired prognosis. And this is seen in several cardiovascular conditions. Okay, so these are the hemodynamics. These are the things we need to take note of. Like we said, mean pulmonary artery pressure more than 20 is the definition of pulmonary hypertension. Okay, so pre-capillary, of course, if there's pulmonary hypertension, the mean PAP will be more than 20. Okay, the wedge pressure will be normal, will be less than 15. Okay, and the pulmonary vascular resistance will be elevated. So this is what we see in 1, 3, 4. Okay, if you have isolated post-capillary, because post-capillary, they now divided into two. It can be IPCPA, that's isolated post-capillary pulmonary hypertension, or combined post-capillary pulmonary hypertension. So for isolated, you have the pulmonary artery wedge pressure more than 15. Okay, but the vascular resistance is normal. It's less than or equal to 2 Woods units. Okay, but even if you have group 2 pulmonary hypertension, over time, you realize that there now becomes the pulmonary vasculature begins to remodel. Okay, so the vascular resistance begins to increase. Okay, so even if it starts as group 2, over time, you can now have pulmonary vasculature remodeling, and it will now give us something that looks like a pre-capillary. Okay, but this is now combined post-capillary pulmonary hypertension. Okay, so what differentiates is that the wedge pressure is still elevated, giving you an idea that the LV diastolic pressure is elevated, so it's coming from the left heart. Okay, but this time around, the vascular resistance, pulmonary vascular resistance is more than 2 Woods units. Okay, I've talked about the exercise one. Okay, so like we all know, the classification, there are 5 classes or 5 groups. Let me put it that way. There are 5 groups. Okay, group 1 is known as pulmonary arterial hypertension. Okay, they are idiopathic, heritable, and associated with drugs and toxins. Okay, they now have group 1 associated with other diseases such as connective tissue diseases, HIV, portal hypertension, schistosomiasis, congenital heart disease. Okay, even persistent pulmonary hypertension of the newborn. Okay, group 2 is pulmonary hypertension associated with left heart disease. Of course, left heart disease from any heart failure, from any cause, preserved ejection fraction, reduced ejection fraction, mildly reduced ejection fraction, valvular heart disease, mitral stenosis, mitral regurgitation, all of them. Okay, congenital diseases and all that. Group 3, like we know, is uh, pulmonary hypertension associated with lung disease. So all lung diseases, obstructive lung diseases, emphysema, OSA, all of them can all come here. Okay, group 4 is the one due to obstructions. Of course, the typical obstruction is CTEPH, that's chronic thromboembolic pulmonary hypertension. Okay, but any obstruction apart from thromboemboli goes to group 4. While group 5 is anyone that doesn't fall between group 1 and 4, enters group 5. Okay. It's important for me to say this here that in pulmonary hypertension, it's not really the etiology that is the problem. Okay, it's actually how will I put it now? It's actually the mechanism underlying the etiology. Let me explain. For example, if you look at scleroderma, scleroderma can cause pulmonary hypertension through different ways. Okay, scleroderma can cause a group 1. Okay, if it causes pulmonary vascular remodeling, scleroderma can affect the heart. Okay, it can cause myocardial fibrosis. And can cause a group 2. Okay, scleroderma increases chances, it can cause lung fibrosis and can cause group 3. Okay, scleroderma can also cause group 4 because it increases the chances of thrombosis and embolism. So scleroderma patients are likely to have venous thrombosis and pulmonary embolism. So it can also cause group 4. So it's really in classifying these patients in whether it's 1, 2, 3, or 4. It's not actually saying it's HIV, therefore it's group 1. Okay, it's actually looking at the mechanism, because if HIV causes HIV cardiomyopathy, that goes to group 2. Although we also know that HIV can affect the pulmonary vasculature itself and cause a group 1. So the underlying mechanism is more important than the disease. Okay. All right. So pulmonary hypertension is a major global issue. It can affect everybody. The prevalence is said to be 1% of the global population. Okay, of course, group 2 pulmonary hypertension is the commonest. So things that cause group 2 will be commoner than any other one. Okay, so cardiac and pulmonary diseases are higher in individuals more than 65. Therefore, of course, pulmonary hypertension will be more common in older individuals. Okay, for group 3, lung disease, especially COPD. COPD is the most common cause of group 3. Important causes in resource poor settings include HIV, schistosomiasis. High altitude is also there for people who live in those areas. Okay, so they present with mainly shortness of breath, okay, fatigue, syncope, chest pain, palpitations, and so on. Okay, they can also have hemoptysis. Okay, then of course, if they have right heart failure, they can start retaining fluid. Okay, then they can also present with syncope. Other symptoms, of course, with pulmonary hypertension for lung, you have pulmonary artery dilation. There can be compression of the left main coronary artery, okay, which will now lead to exertional chest pain, anginal chest pain. There can be compression of the left recurrent laryngeal nerve, okay, leading to what we know as Ortner syndrome. Okay, the compression of the bronchi that will cause wheezing, cough, infection, even a lung collapse. Okay, so the pulse, they have a low volume carotid pulse with a normal upstroke. They may have A wave, maybe A wave in JVP, or maybe large. V waves are prominent in severe pulmonary hypertension. They have a left parasternal heave, right ventricular hypertrophy. P2 may be palpable, it will be loud. They have a right ventricular S4. You hear the S4 more at the left lower sternal border. Then if you have tricuspid regurgitation, they may have an S3 of right ventricular origin. Okay. So later they present with right heart failure, hepatomegaly, peripheral edema, ascites, cyanosis if there is lung disease and PQ mismatch. Okay. So with disease severity, they have dyspnea. Of course, it usually starts with dyspnea on exertion, progresses to dyspnea at rest, with low cardiac output and metabolic acidosis, hypoxia, features of right ventricular failure, syncope, then RV ischemia can cause chest pain. Okay, so these are some of the signs that um we've talked about. Okay, they may have an accentuated pulmonary component of the cell, that's loud P2, aggravated heart sounds, that's S3. They may have a systolic murmur of tricuspid regurgitation. They may have a diastolic murmur of pulmonary regurgitation. Of course, JVP, signs of RV backward failure, the veins, the blood tends to pull back, enters the JVP, enters the liver, ascites, peripheral edema. Okay, there are also signs that you may see that will give you an idea of the underlying cause. Okay, you can have digital clubbing, suspect cyanotic heart disease, fibrotic lung disease, bronchiectasis, okay, liver disease. They can have differential clubbing or cyanosis, suspect PDA or SMNJA. Okay, so if it's from CTEPH, you can look for a DVT, lateral leg swelling and pain. Okay, they can have scleroderma, may have telangiectasias, okay, and others. Okay, then They could also have signs of RV forward failure, such as peripheral cyanosis, dizziness, pallor, cold extremities, and prolonged capillary withdrawal. Okay, so investigations, of course, routine blood tests. You want to look for if you can get the etiology, HIV, hepatitis, immune disease, if there's connective tissue disease, liver, LFTs, renal function, thyroid function, BMP, chest X-ray, ECG, echo, cardiac MRI, pulmonary function test, abdominal ultrasound, right heart catheterization. Okay, so this represents a summary before we take them one after the other of the findings and investigation. Okay, one thing you may be able to see on chest X-ray is enlargement of the central pulmonary artery. Though it's not usually clear on X-ray, but it's possible. On ECG, it's important to look for features of right heart strain. Actually, we saw a patient, I think either this week or last week, the surgeons called us to see a patient that they wanted to operate. So the patient had T-wave inversion in V1 to, I think, V5, T1 to V5 or V6, I'm not sure again. T1 to V5, V1 to V5, okay? Then he had this early R wave progression. Okay, so echo was normal. Every other thing was basically normal. She was not symptomatic, okay? But because of that, and recently we've been seeing a lot of pulmonary embolism, especially in young persons. Okay, so because of that T-wave inversion, we asked to do the dimer, and dimer came out, was very elevated, and we sent for CTPA. This woman had multiple clots. Okay, somebody that, of course, she had risk factors. She had been immobile for like a month after the accident, she had an accident and all that. So it's important for us to look for it in the ECG, right axis deviation, precordial T-wave abnormality. These are early signs that that can be picked up on ECG. Okay. You can have, if you do spirometry can give you restrictive pattern. Okay. Then perfusion abnormalities, if you do VQ scanning, chest CT is important. It may show you the diagnosis, if it's lung disease, if it's COPD, CTEF, chest CT is important, or CTPA if you're suspecting pulmonary embolism. Okay, echo, I'll talk about echo in detail, but echo, right ventricular enlargement is something that you have to look for on the echo. Okay, then contrast echo if necessary, Doppler, then exercise testing. Okay, chest X-ray is abnormal in most patients with pulmonary hypertension. However, a normal X-ray does not exclude pulmonary hypertension. It's important to know that X-ray can be normal. Okay, so what you see is basically right atrial enlargement. You know, the right border of the heart is formed by the right atrium. So you can see a protrusion of the right border of the heart. You can see pulmonary artery enlargement, sometimes pruning of the peripheral vessels. Okay, then you can see RV enlargement, right ventricular enlargement. This one you see it upturning of the apex if the right ventricle is enlarged. Then other signs, underlying cause of pulmonary hypertension. Okay, you may see fibrosis, all those things in the lungs, lung disease that suggests a group 3. Okay, so this tries to show large dilated pulmonary artery. Then prominent pulmonary artery segments. These are X-rays. Okay. So ECG, this is from the guidelines. So ECG will show P pulmonary, right axis deviation, right ventricular hypertrophy, R over S greater than 1. Okay, you may also see right bundle branch block, complete or incomplete right bundle branch block with strain. Okay, that's ST depression. You may see a strain pattern, ST depression or T-wave inversion in the precordial is V1 to V4, and also 2, 3, and AVF. Then prolonged QTC may be seen, although it's non-specific. Okay, so this ECG tries to show CT wave inversion see ST depression in V2, V3, features of RV strain. Then he also has high ventricular hypertrophy and P pulmonary. Okay, it's basically the same thing here. Although this one now has right bundle branch block. Okay, so echo, it's important we know in detail the echo features of pulmonary hypertension. I just brought this also from that guideline and I took them one by one. The ventricle may be enlarged on parasternal long axis view, enlarged right ventricle. Okay, of course, normally the left is a higher pressure chamber, it's usually larger than the right. Okay, so when the right is larger than the left, it tells you that there is RV pressure overload. Okay, so when you do the B, when you do the basal RV over LV ratio is greater than 1 on 4 chamber. This is not how it should normally be. Okay, then when you do short axis, you can see a D-shaped septum. Normally, the anatomy of the right ventricle, okay, the anatomy of the left ventricle, so that the left ventricle has concentric, it has muscle, okay, unlike the right ventricle that is thin walled, okay. So normally this C, the picture C, it should be round. Okay, so when you are seeing a D-shaped septum, okay, it tells you that there's, like you can see the arrow, the RV is pushing the LV, the pressure is high. Okay, you can also use this to get what is called the eccentricity index. Eccentricity index should be 1. If you take, inside the LV, there are blue arrows. So if you take the AP, I don't know whether it's the inferior, the up and down diameter and the left and right diameter, permit me to use that. It should be 1. Okay, but this you can know because of the pressure to be less than that. Okay, another thing you can see is the standard of in D, you can see the standard IVC with diminished inferior inspiratory collapsibility. This is seen on subcostal view. Okay, then if you do short axis or E is short axis, you can see a short acceleration time, okay, with mid-systolic notch. Okay, anytime you see a mid-systolic, I've never seen one, no, but they said that anytime you see a mid-systolic notch on echo, it's indicative of pre-capillary, mostly group 1. Mid-systolic notch is really characteristic of group 1 pulmonary hypertension. Okay, if you do RV systolic function, fractional area change will be low, less than 35. Then TAPSE will also be reduced, okay, less than 18. Okay, then if you do peak systolic if you do peak systolic velocity of the tricuspid annulus, it will be less than 9. That's if you put tissue Doppler on the tricuspid annulus, it will be less than 9.5 centimeter per second. Okay, other things you see in echo, dilation of the right atrium. In fact, this one is usually subjective because once you see a right atrium that is larger than the left atrium, I think you should, even if it's like if you get a left atrium of maybe 10 centimeters squared and you're getting a right atrium of maybe up to 15, 16, even if it's not up to the cutoff, you should compare to the left. The left is usually larger than the right. Okay, then of course, tricuspid regurgitation is very important. Okay, if you are getting significant TR velocity more than 2.8 meter per second, okay, when you do continuous wave at the tricuspid valve leaflet is significant. Then you can also, with echo, estimate the right atrial pressure using the IVC collapsibility. If it's less than 2.1 centimeter and it collapses, if the IVC is diameter is less than 2.1 centimeter and it collapses, the collapsibility is more than 50%. Estimated right atrial pressure is estimated to be 3 millimeters of mercury. If the IVC is dilated more than 2.1 centimeter and the collapsibility is more than 50%, which is adequate, it is estimated to be 8, 5 to 10 millimeters of mercury, average of 8. Then if it's still dilated and it is also is poorly collapsible, the right atrial pressure is estimated to be 15. Okay, so the systolic pulmonary artery pressure is obtained by measuring the pressure gradient. Of course, the pressure gradient is gotten from the Bernoulli equation 4V squared. And you now add the pressure gradient to the right atrial pressure. So this gives us an estimate known as the systolic pulmonary artery pressure. Okay, the last sign we can see on echo is pericardial effusion. Okay, you can see it in any view, four chamber, longer, short axis, all of them, subcostal. Okay, so another thing is that is important to assess. From the guidelines, they talk about assessing because the gold standard for pulmonary hypertension is actually the please, I don't know if you can give me just a minute or two. They just took our light, so let me on the light for the. If you can just give me a minute or two, I'll be glad. I don't know if I'm permitted. Hello, can I continue?
Yes, please. Please
Hello.
go on. Go on, sir.
Okay, thank you. Thank you. I'm very sorry for this. Sorry. Like I was saying that the right heart cath is the is the um, is the ideal way to assess pulmonary pressures. Okay, so what echo in the guideline now advise that echo gives you the probability of pulmonary hypertension to know whether you will proceed to a right heart cath. So what is used is the TR velocity. If you are having a TR velocity of less than or equal to 2.8, okay, with no echo signs, okay, the probability is low. That's why if you look at the left of this, less than or equal to 2.8, N means no echo signs. Okay, the probability is low. Okay, so if there are now risk factors or risk factors, associated conditions, and all that, if there's none, you should think about an alternative diagnosis. If there are, you follow up with echo. Okay, now if the probability is yes, you have a low TR velocity, less than or equal to 2.8, but with other echo signs, so it pushes it to intermediate. Okay, pushes it to intermediate. Okay, and if there are risk factors or other associated conditions, this person now should get a right heart cath. Okay, this is a class 1 indication. Okay, so if the TR velocity is intermediate between 2.9 and 3.4, okay, and there are other echo signs. Okay, we've talked about the echo signs, but I will tell us in the next slide how the echo signs are classified. Okay, so just that alone, 2.9 to 3.4 is intermediate. Okay, if there are risk factors or associated conditions, that person should get a right heart cath. If there are no risk factors, the person should just be followed up with echo. Okay, but if the TR velocity is high, the probability of that's more than 3.4, probability of pulmonary hypertension is already high, and that person should already move straight to a right heart cath. So these are the echo signs. There are things we have talked about already, but they were now they classified them based on whether it's the ventricle, the pulmonary artery, or the inferior vena cava and the right atrium. Okay, so you need to push it, you need signs from at least two categories. That's what the guideline says. Okay, to alter the echocardiographic probability of pulmonary hypertension. So you need a sign from the ventricle, maybe you are using the eccentricity index, the TAPSE, or the fractional area change, whatever it is. You have one of that. Then you have one sign from the pulmonary artery, maybe dilated pulmonary artery more than 2.5 centimeter, or you have pulmonary regurgitation, or you have low acceleration time. Okay, so you need a sign from the IVC, dilated IVC, or an enlarged right atrium. Okay, so you need at least signs from two components here to be able to shift the probability. Okay, and that thing echo helps you to do, apart from these things we have talked about, we've talked about echo helping you to assess the severity of pulmonary hypertension and know whether the person needs a cath or not. So echo also helps you to give you an idea of the diagnosis, okay? If you are dealing with type 2 pulmonary hypertension, if it's mitral stenosis, of course, you see it. Mitral regurgitation, you see it. whatever it is that is causing it, congenital heart disease, a VSD, echo will help you make that diagnosis. Then echo may also help you to show signs of type 4. If it's CTEPH, you may see the McConnell sign, IV free wall hypokinesia. You can even see the 60-60 sign. These things are seen in type 4, group 4. Okay, so these echo pictures just attempt to show the progression of pulmonary hypertension from mild. This one, if you see the short axis, the septum is not fully D-shaped, it's going towards D-shaped. Okay, if you the RV is becoming dilated, but it's not so dilated when you compare it to the LV and all that. Then the TR, you can see the TR, the color. Now, one of the ways you know severe TR is by the density of the jets when you put your continuous wave. Okay, so it's not that dense, but by the time it gets to moderate, you can see that these pictures are not so clear, but it begins to shift. Okay, by the time it gets to severe, you can see the TR. Look at this short axis. Okay, you can see how the RV is so big. You can see the RV is so big and entirely compressing the LV. Of course, this is severe pulmonary hypertension with RV failure. Okay, I've talked about TAPSE. TAPSE should be less than 1.8, has negative prognostic implications. I think I can just move on. Okay, so like I said, right heart cath is the gold standard for diagnosis pulmonary hypertension. It requires expertise and meticulous methodology, and you should be done following standardized protocols. Okay, so the indications for right heart cath, you want to diagnose and classify it. You diagnose the pulmonary hypertension. What group is it? To tell you, you can also use it for hemodynamic assessment. Okay, for transplant candidates. Okay, it can also help you in patients with shunts. Can actually diagnose shunts, and it's relatively safe in centers centers with high frequency. The frequency of adverse effects is low, and frequency of procedure-related mortalities is also low. It's contraindicated in patients with a known thrombus or tumor. If there's a thrombus or tumor in the right ventricle or the right atrium, is contraindicated. A pacemaker that was recently implanted is a contraindication. Then acute infection, of course. Then mechanical right heart valve, either a mechanical tricuspid valve. Okay, nobody really puts a mechanical pulmonary valve.